So this is also live on tune in there. If you have to leave or whatever, it'll be kept on YouTube, and you can go back and watch the rest of it. So what I would recommend for the people that want to definitely talk in the comments, put their answers in the comments, because what I usually do is I usually have like a list of people participating. Since this is more open today, I'm basically look down the list and check people off. So all right. And then feel free to talk as well. It's always better like when we have like that interaction. And I will be calling out people that are active in the comments. So on YouTube as well, if people are watching from YouTube, I will be using the comments from YouTube and putting them into the chat so I can answer them there as well. All right. So we're going to do a case unknown. I haven't gone through this case either. It looks like it might be a little shorter than the previous case. So over here, like I think the last case was like way longer. So hopefully this won't go 2 hours. But all right, and then at the end, if you have any questions about med school, about the program, about anything, I can stay a bit and we can talk about it. All right, cool. So let's start it off. So we have a 45-year-old white man who comes to the emergency department because of a 6-hour history of acute onset left-sided lower abdominal pain. He describes the pain as starting over his left flank and radiating down his groin. The pain comes and goes, but is intense when present. He has some mild nausea without vomiting. The pain does not change when eating. The pain is less when he walks around than when he sits and lies flat. He has not had any bloody stools, black stools, or change in bowel habits. He denies diarrhea and constipation. He has noticed his urine looks dark, but denies pain during urination and urinary frequency. States he swims several times a week for exercise, and his pain started immediately after swimming. He also notes that several days ago his son ran into his left side while playing football. He took some acetaminophen, which minimally relieved his discomfort. He now presents for evaluation at the emergency department because of the pain that has not subsided. He says he has never experienced anything like this. So with that history of present illness, and if we can maybe post a link on the YouTube channel in the comments, that would be great. Let me do that. That way you guys can follow along as well. Okay. So with this HPI, does anybody want to take a stab at what they gathered from this? Let's see. Dr. Zhang, do you want to try it?
I said that probably eliminates diverticulitis because, first of all, there's no bloody stool, which is usually a symptom of that. Also, he seems to be pretty healthy, and so he doesn't really have because I remember that usually comes with not exercising a lot too, but it seems like he exercises a lot with swimming and everything.
Yeah, so it seems like he is active. We don't know exactly how much. He said, I forget what he said. He usually swims several times a week for exercise. The one thing that I was going to say about the diverticulitis is, yes, it can present with bloody stools. I've seen it present without bloody stools as well. A lot of times what I see is left lower quadrant pain, fevers, chills, and sometimes it can have some diarrhea. It doesn't always have to be bloody, so I would just keep that in mind. But in general, yeah, diverticulitis can maybe cause something like this. What else? What about the onset of the pain? So, Dr. Hitz, you want to try that?
I'm sorry, can you repeat the question?
So, the onset of the pain and the location. What are you thinking of? So, it's a 6-hour history of acute onset left lower abdominal pain.
I'm not exactly sure.
Okay, so that's okay. So we're looking at acute onset, right? So this is not like it wasn't super quick. It didn't start. I mean, it was pretty quick. Sorry, it wasn't like it started a week ago and it's getting worse. So there was an acute process that happened. So so it's if you have like something like mesenteric ischemia or a what is it called? Like low blood flow to the intestines. A lot of times you'll have like symptoms before then. I think somebody had mentioned mesenteric ischemia, and so things like that where you have those prodromal symptoms are a little less likely, especially if it's that acute onset pain. What about the left lower quadrant? So what kind of lives in there? What would you be thinking of?
Appendicitis.
On the left side, not the right side.
Oh, the left side. The bladder.
The bladder The bladder is a little bit more midline, but you do have it is a little on the left side too. So the bladder. What else?
The colon.
The colon. Yeah. So that descending colon is going to be there. I think the diverticulitis fits with that because it's in that left lower area. What else?
I'm just reading like the comments here too. We're saying the bowel.
So the bowel, the colon. What about the kidney? Do you think the kidney you would have pain in the left lower quadrant?
Isn't that more towards like the back?
So you'll have kind of in the flank area or like the back area, but the kidneys do push urine down. So maybe in that urinary tract you can have that type of pain. Does that make sense? I think, and then he also said it's like, did they say it radiated to the groin?
Yeah.
So that can also that fits in with that. Yeah. Okay. What else did anybody catch in there? Okay. So, Dr. Sartip, what are you thinking about by his son hitting him with the football?
So I was thinking that if his son, like if they're playing like pretty aggressively, and then his son had like ran into him, that might have caused like some bruising of like somewhere on the lower left side of his abdomen, which is probably like why he's experiencing like the pain.
Potentially, yeah. So it can be musculoskeletal. He can have that pain from there. He could have pulled something or tore something. So yeah, definitely. When we think about high impact sports, so like football, a lot of times we're thinking of like a spleen rupture. So if for whatever reason somebody has an enlarged spleen or that it's inflamed, so that can be from viral illnesses like ED or mono. You can have a higher risk of rupturing that spleen, and the spleen is very vascular. So if it ruptures, if it gets injured and starts bleeding, it's going to pour blood, and a lot of times you pour blood into the belly. Most of the time you'll have generalized pain, not so much in a specific part, like he's saying in that left lower side, but the peritoneal cavity is so from your diaphragm to your pelvis, it's all kind of one area, so that blood can kind of seep down as well. But it's a little less likely. But the fact that he had some trauma, like you said, it is something that we have to keep in mind. Okay. Dr. Dr. Amina, you're saying that he might have contracted something from swimming. You want to talk a bit about that? If your mic doesn't work, that's okay. So typically when we think of...
Can you hear me? Can you hear me?
I can hear you.
Okay. Okay. Yeah, I'm not really sure about the name of the bacteria, but I remember that they were saying that there are some type of bacteria very tiny that can go into your bladder when you pee in the either a pool or even just swimming in general, and that might have introduced that type of bacteria and then caused some type of inflammation.
Yeah, I'm blanking on the name. I think it's a parasite though. I don't think it's a bacteria. Okay. If somebody knows what the name of that organism is, feel free to comment it. But yeah, I mean, less likely if he's here in the U.S. And especially like the pools are chlorinated and all that. Sometimes like when people have, if you don't have a really clean pool and people kind of poop in the pool, you can have that bacteria if you accidentally drink the water, and that can cause that. Okay, is it crypto? I don't think it's crypto. Or I don't think it's tapeworms either. Okay, so let's go over like how I would approach this. So he has a 6-hour history of acute left-sided abdominal pain. So with that history, on that left lower quadrant, things that I think about are diverticulitis. I would think about the ureters going from the kidneys traveling down into that left lower side and then hitting the bladder. You can have a bladder type infection, though that is usually more midline. You can also have like musculoskeletal issues back there, and what else can be in there? Oh, and then if you're a female, of course, you have your ovaries there, so you can have an ovarian torsion. Him, it's a little, maybe he's a male, so not likely. The other thing is if he had like a scrotal torsion, so the or testicular torsion, so the left testicle was like twisted and cutting off its blood supply. A lot of times you're going to feel it in the abdomen, but he would probably present it with testicular issues. So maybe a little less likely. All right. So he describes the pain as starting over the left flank and radiating down his groin. So that's pretty consistent with a urinary issue. So maybe an infection or maybe even a kidney stone that's coming from the left side going to his groin. We would see usually some blood in the urine. So I don't know if he mentioned he had blood. So we would keep an eye out for that. It comes and goes intense when it's present. And that actually is pretty consistent with the kidney stone. A lot of times you'll be walking or moving around and you'll have pain as you move because that stone gets lodged either usually in the ureter, and as you move, you're moving that inflamed area, and so that can be very painful. He has mild nausea and vomiting, so again, you will have that with a kidney stone. You can also have that with like enteritis as well, so like a infection of the stomach or the GI tract. All right. He has not had bloody stools, black stools, or change in bowel habits. So let me see. Okay, so he has not had. The urine. So I have a comment saying his urine is dark, so it could be a sign of dehydration. Okay, so do you want to explain a little bit about what you mean by that, or what your thinking is there?
Can you hear me?
Yeah.
I'm thinking it could just be like there's more filtrate in the urine, and since we haven't done any tests yet, we don't know if it could be like increased BU and creatinine or other like proteins or something.
Sorry, I cut out. What was the last thing that you said?
Like we haven't done any kidney tests, so we don't really know what is in the urine, but there's definitely less water compared to solute concentration there.
Yeah.
Sorry. Like if it also is bacterial, maybe it could be a sign of sepsis.
So yeah. So because a lot of times when you have that type of infection, if you have sepsis, or if you're just if your urine is dark in general, there's a few things that can be going on. So one, you can be very dehydrated, like you're saying. So if he's vomiting a lot, that would be a cause of the darker urine. If there's blood in it, that can make it look more amber color instead of just bright red or dark red. So that is also a possibility. And then the last one is if he has a liver injury. So liver processes bilirubin, which is a breakdown product of our blood cells. So our red blood cells cycle themselves over every 3 months. So basically every 3 months you're having a new set of blood cells. And so when they die off, they break open. And so that bilirubin is taken up into the blood, taken to the liver, and broken down and excreted. So some of that is going through the stool, and some of it goes through the urine. And so bilirubin and its big breakdown products are what cause our stool to have the brown color it has, and makes our urine more of that darker color that we have. So if somebody had a liver injury, they would also have dark urine. So that was one thing that I was seeing here. I mean, it's not super consistent with that. Your liver is in the right upper quadrant, and he's having pain on the exact opposite side of his belly. But whenever somebody says that they have dark urine, I always think of that. But yes, I think most likely you're correct. In this situation, it's probably a sign of dehydration. But good. All right, we talked about his swimming, and we talked about his son hitting him while playing football. So he took some Tylenol, which helped minimally relieve his discomfort, and the pain is persistent. Okay, any last thoughts about his history of present illness? We have basically left lower quadrant pain. We're talking about diverticulitis. We're talking about muscle issues. He's not a girl, so we're not saying ovarian torsion, but maybe testicular torsion, although less likely with his presentation. Kidney stone is pretty high because he's having pain while he's moving. It looks like, it looks like he's having more pain when he's moving, and then his urine is dark, so maybe that's blood. Possible kidney infection, though it doesn't say he has fever. Any other thoughts that you guys have? Okay. All right, so let's move on. And if you can't see my screen anymore, then let me know. Okay, so review of systems. So he, I think somebody mentioned also inguinal hernia, which is very fair, yeah. So left-sided lower abdominal pain can be an inguinal hernia. So Dr. Safe, do you want to talk about inguinal hernia and how this would fit the picture, or how it wouldn't?
Okay, let's see. Let's see. Denied shows denied rushes. So far, it can fit the picture. I mean, especially the fact that if he had maybe possible trauma towards that area, that can definitely be a potential way to cause a hernia.
Okay.
Let's see. No vomiting, no constipation. That last one. If I would wonder, I'm not quite sure, but wouldn't inguinal hernia affect if he tries to breathing or just having that what's it, belly breathing? I think what it is. If they try breathing and see if there's any pain or rigidity.
Yeah. So we have pain with the hernia typically when it incarcerates, right? So if you have a hernia, that's basically a loop of bowel that gets stuck into this opening, usually the inguinal ring. So it goes in and it ends up getting clamped off, and the blood supply is no longer getting to the actual bowel. And so that bowel can start to die. And so like you're saying, if we increase pressure in our belly and it's starting to push down on that hernia, it might not necessarily cut off the blood supply, but you'll see more of a bulge there. So a lot of times a patient will come in complaining of a bulge that hurts, so either in their belly or in their groin. And if it is incarcerated and that bowel is dying, a lot of times they'll have a pretty tender abdomen there as well.
Yeah. I was gonna say check if it was tender or rigid. We can help determine. I mean, and just the possible sign, just seeing it, if there's a bulge.
Yeah, exactly. And that's and I didn't really think of it because most people that present with a hernia will say like, "Hey, I have this big bulge that's hurting," but I've seen crazier things. All right, so review of symptoms. He's otherwise felt well before the onset of his current symptoms. He has no fevers, chills, weight loss, and fatigue. No rashes or itching or any lesions. No palpitations or chest pain. No lower extremity edema. He has nausea when the pain is at its most intense, but no vomiting. Oh, I thought he said that he was vomiting. Okay. No constipation or diarrhea. Last bowel movement yesterday. No hematochezia or melena. No appetite. Has not eaten since the pain began. No dysuria, hematuria, urinary frequency or urgency, or increased volume of urine. States the urine appears dark. Occasional lower abdominal pain and strenuous activity, and the rest is non-contributory. Okay. All right, Dr. Saya. Tell me about how the patient generally looks.
He generally looks.
What he's saying.
He looks healthy. I was worried about blood in his urine, but he denies all of that because the urine is dark.
Well, he denied the hematuria, but he's saying it's dark. So I don't know if I would completely rule out blood in the urine because you can have kind of like an amber type color to urine that can be blood. But but that I agree. Usually if there's blood in it, the patient will tell you. But yeah, keep going.
I think the nausea I would have to be careful of. Okay. He is healthy. He has no like rashes or anything like that. It could be something related to his kidney, but I'm not sure, honestly.
Okay. So let's look at the general one first. So he's felt well before the onset of the symptoms. So like you're saying, he sounds pretty healthy. I don't think that's a huge deal. He denies fevers, chills, weight loss, and fatigue. So fevers and chills, let's take that one first. So what are we thinking about when we say fevers and chills?
An infection or like inflammation?
Yeah, so like infection or inflammation, exactly. So he's denying it, so it's probably not an infection. Yeah, maybe. You can have infections that you don't present with fevers and chills if they're like early on in the course, but if he's coming in the ER, usually that's kind of very severe at that point, so less likely. Weight loss and fatigue, what about that?
The only thing that comes to mind is diabetes for some reason, but...
Okay. Yeah, you depending on the control, you can have weight loss and fatigue. What about something very worrisome? If somebody tells you, I've been losing weight, I lost 20 pounds in the last month, what would you be worried about? and they're not trying to lose weight. They're eating everything they can, and no matter what, they keep losing weight.
I'm not sure, honestly. Someone says bowel obstruction in the comments, but
Maybe if you scroll down, I think cancer. Right? So cancer definitely comes to mind. So whenever somebody tells me they have unintentional weight loss, I automatically think cancer, because there's not a lot of things. There are a few other things, but there's not a lot of things that will cause unintentional weight loss over a short period of time. And the reason why cancer does that is basically the cancer is outcompeting your body for nutrients. Cancer is very good at getting nutrients to it. It gets more blood vessels there. It grows rapidly, and so it's starting to eat way more of the nutrients than your body can, and so your body can't compete with that, and it starts to eat its own eat itself up. So it starts to use fats as energy. It starts to use proteins as energy. You have muscle breakdown, and that's why people generally look cachectic. They look like they're almost wasting away, in a sense, and so that's what cachectic means. Cancer is generally what I think of when I hear like unintentional weight loss. Fatigue will also be caused by cancer as well. So that was a long aside for something that's not really relevant to the case, but because he denies it. But yeah, good. All right. You talked about the rashes, no rashes or itching or any other lesions. So good. And then I don't know if there's anything else in here that's significant. Okay.
I have a question.
What's up?
Could we also rule out hernia too because he's not constipated or there's nothing wrong in terms of his bowel movements?
Yeah. So a lot of times you can have some constipation. I don't know if you can rule it out, but it would go lower on the differential. Especially if it's a non-incarcerated hernia. What I would say though is if he is having a incarcerated hernia with necrosis of the bowel, a lot of times I think you would have some nausea, you would have some vomiting, and I've seen a good number, and I have to look back to see if this is a typical presentation, but I've seen some with like a bloody bowel movement, because that bowel is dying, you're bleeding into that area of the colon as well. But I don't know if that's a typical presentation of an incarcerated hernia. But good question.
Thank you.
All right.
I have a question.
What's up?
So, also, can we rule out a UTI? Because if he's not having any pain while he's urinating, or there's no infrequency, and there's no temperature spike as well, like this is fine, then can we rule it out, like, for the most part?
So UTIs in general won't typically cause a fever. When we're talking about UTI, especially like early on, when we talk about UTI, it's usually located in the bladder. And actually, I take that back. They do sometimes cause fevers, but because it's very local in the bladder, it's not a systemic response until it goes up and starts to infect the kidney. I don't see a ton of fevers. I usually will see, like you said, pain with urination. So that's usually in the form of burning. They'll pee a bit more than usual. And then sometimes they can have urine like color or odor changes. So those are usually the symptoms of a UTI, which I think he's basically denying. So no fevers, no nausea or vomiting, so less likely like a pyelonephritis or an infection of the kidney. And then, I don't know, did it say that he wasn't peeing blood? Yeah, no hematuria, just that or dysuria, or frequency or urgency. So everything. He denies all of that. But yeah, good job.
Thank you.
What else? Anybody else have any? any ideas? Okay. I think I got to most of those comments. He has occasional low back pain with strenuous activity. I don't know if that's actually relevant. I guess if that's where he was hit, maybe that's causing his pain. All right, and then like we talked about, no dysuria, hematuria, urinary frequency or urgency, or increased volume of urine. So it doesn't hurt when he pees, so that's the dysuria. No hematuria, he doesn't have blood in his pee. He's not peeing more frequent, and doesn't feel like he really needs to go when he has to go. Just that it appears dark. And then for the GI system, he does have nausea when the pain is intense, but no vomiting. No constipation or diarrhea or blood in the stool. Makes me think less likely a colon issue, but it can still possibly be colon. So with all of that, right now, does anybody want to tell me what they're thinking of with the HPI plus the review systems? Dr. Sammy, do you wanna kind of take a stab at that? Why? Like, what do you think is going on in this patient?
Just one question before.
Yeah.
Because we haven't said we ruled out dehydration. Just when I've experienced dehydration before, I would note that like I wouldn't be peeing at all for long periods of time, and he hasn't said anything about changes in frequency and urinating. So would that technically rule out dehydration?
Yeah, that's a really good point. I wouldn't say it rules it out, but it would be lower on the differential, especially because dehydration in general wouldn't cause all of the symptoms that he's having. It typically doesn't cause that lower type pain, but it can be a symptom of what's underlying. So, maybe he's not dehydrated. And like he said, he's not reporting decreased urinary frequency. So yeah, you're right. So what do you think is going on with this patient? Like, what's higher up in your differential?
So a lot of the comments have been saying UTI before, but as you mentioned before, there's no sign of fever, so I would kind of lower that on my list, or like completely eliminate a UTI, just an infection as a whole. He denies like pain when he pees, blood in his pee, and sometimes with the strenuous back pain, people on my team has had kidney stones have complained of back pain as well.
Yeah.
And so I would look to, and as the comments are saying as well, look to kidney stones.
Yeah.
And just because he said he got hit in the back as well, hit in the left side while playing football with his son, might have either aggravated something, or we would be looking for some sort of maybe partial rupture. But kidney stones are definitely higher on my list than like a rupture of something.
Okay, yeah, and if it were a rupture, especially if you got hit on that side, when we're talking about probably splenic rupture, right?
Yes.
So you would generally have more abdominal pain more than anything, but it would be important to look at our abdominal exam and kind of see from there. But good job. So yeah, I agree with you. I think right now it seems like a urinary issue, probably a kidney stone. This dark urine, I'm still kind of wary about. I think that might be blood. Just doesn't look like blood when it comes out. But who knows? Maybe actually he had a kidney injury where it was actually a traumatic laceration of the kidney. A lot of times, I don't know. Would it pour into the urinary tract, or would it just kind of come out into the peritoneal cavity? I don't know. Maybe both. Okay. Dr. Iman, you're saying that isn't it less likely to be a kidney stone because he has increased volume of urine? What do you mean by that?
Well, isn't it like if you have a kidney stone, like you're not able to pass urine, and like it says that he is able to pass urine, right?
Yeah, it seems like he is. Like he denied increased volume of urine. So
Okay.
Yeah, I don't know if it specifically said that he had an increase or if he had a decrease either.
Okay.
But no, I mean it depends. So to answer your question, if you have a bilateral kidney stone, you can have a decrease in urine output because you're basically blocking off both sides of the urinary tract and you're not peeing anything out, so it'll back up into the kidneys. If you had a one-sided stone and it was blocking off just that one side, the other side is still peeing. You probably, I don't know if you would have a decreased urine output with that. I'd have to look into that.
Okay.
I have a question.
Yeah.
I don't think we have our vitals checked or anything. But say if this person's vitals are, or specifically the blood pressure is high, would we want to definitely think more focusedly on the kidneys as well too, because the kidneys does have a role in affecting blood pressure?
Yeah. So if we're thinking about, you're talking about the renin aldosterone angiotensin system, right? So
correct.
When you have decreased flow to the kidneys, your kidneys will think that you're super dehydrated, and it'll want to start retaining more urine or retaining more fluid by decreasing the output of urine. And so that's a whole system that your kidneys will, a whole signaling pathway your kidneys will go through, so that you're able to retain more fluid. And so that as you retain more fluid, especially if you're actually not fluid down, your blood pressure will increase. So potentially that can potentially happen. But yeah, it would be a good idea to keep an eye on the vitals. The only caveat to that is when somebody's in pain, their blood pressure is generally higher. So we would have to kind of see what the whole picture is. Dr. Khan is saying we can look for bruises where the kidneys are to see if there's blunt trauma to the kidney. Definitely. Someone on YouTube is saying kidney stones can cause dark urine. They can. And Dr. Anish is saying, wouldn't kidney stones also cause dysuria? And since he denies dysuria, kidney stones would go down in the differential. Yes, kind of. You'll have dysuria more when you're trying to pass that kidney stone, and that's when it'll really hurt. But if you think about it, the kidney stone is way up here in the ureter, or most likely in the ureter. We actually don't know where in the tract it is, but it usually causes pain as it goes down the ureter. So if it's in the ureter and it's stuck, and it moves, when you move, it kind of makes that inflamed portion move, or you have pain as it pushes, it's being pushed down. That is not necessarily when you are peeing, and so the pain with urination won't usually come until you're trying to really pass that stone. For a UTI, it's the bladder is inflamed, the urethra is inflamed. If you have like a urethritis, that is why it's painful when you pee, because that urine is going through that inflamed area. And so yes, it can potentially cause dysuria, but we wouldn't be able to rule it out just because of that. So okay. Kidney stones don't have to necessarily cause a fever. Dr. Vinesh is saying, could we rule out any possible form of hepatitis? So hepatitis is a good thing to think about, because it'll cause that darker urine if you have liver failure. So that'll be important to look at. But I think that I would at this point probably make it lower in the differential because he's not having like right upper quadrant type pain. I recall my teacher having a very high fever when wanting to pass his stone. He might have had an infection at that time. I don't remember seeing a lot of kidney stones with a fever without an infection. But maybe we just treat it empirically if they have a fever because urosepsis is very dangerous. So, yeah, if he was really unwell, it wasn't just a kidney stone. It was probably an infected stone, so like urosepsis. Okay. I think we've got... Oh, somebody on YouTube asked, does his lack of relief from acetaminophen matter? He got a little bit of relief from the Tylenol, but if this was something like a kidney stone, Tylenol is just going to help calm the pain down a bit. It's not going to really take away the underlying issue. Something like an anti-inflammatory may do that, but depending if he has kidney injury, we might not want to do that. So it matters somewhat, but it's probably something that might come up a bit later. Or actually, you know what? If he's taking a ton of Tylenol because he's trying to make his pain go away, that can cause a liver injury as well. But he would have that before. But that wouldn't necessarily cause the symptoms before. The reason why he has pain in the beginning and the reason why he takes Tylenol. So, this is me thinking out loud. This is how I think out loud. So, sorry. All right. Yeah, and then Dr. Safe is saying maybe direct kidney damage if he got hit. Yeah, like we said before. Okay, so let's move on to the next one. So past medical history. So he has diabetes since he was 20. Okay, so he was, 46, I believe? He's well controlled with diet, exercise, and oral medications. He has hypertension, hyperlipidemia, both well controlled on 45. Thanks, Hannah. Well controlled on medications as well. He has obstructive sleep apnea, which he uses a CPAP machine. I don't know if that's super important. He had a recent DVT that developed after a long international flight that is currently being treated with an oral anticoagulant. Denies history of UTIs, difficulty with urination, COPD, renal stones, or immunosuppressive disorders. His surgical history, no abdominal surgeries. His wisdom teeth were pulled out as a teenager. I don't think that's super relevant. He's on lisinopril, aspirin, rosuvastatin, rivaroxaban, metformin, and niacin. Okay. No known allergies. Mother and father have high blood pressure. Siblings have a history of kidney stones. Oh, okay. And he denies current and previous tobacco use. He also works as a desk job and swims laps at his local pool several times a week. Immunizations up to date. No exposure to any sick contacts for the past 15 years. He's had unprotected sex only with his wife. All right. All right. What type of diabetes? Yeah. So, Dr. Is that Dr. Abbas? How do you pronounce your last name? Because I'm going to call on you right now.
Abbas.
Abbas? Okay. So, how do you know what type of diabetes this is?
Because he's taking, where is it? He's taking metformin, it treats for type 2 diabetes.
Yeah, so metformin in general won't really help a type 1 diabetic. So type 1 diabetics they have diabetes because they don't have the ability to produce that insulin. And so metformin helps your body use insulin. So if you don't have insulin to begin with, metformin is not going to really help. So most likely it's type 2. But good. What else in the medical history do you think is relevant?
Are you asking me?
Yeah.
Okay. He said he denies difficulty with urination, so UTI is basically like taken, like down even more. He has obstructive sleep apnea.
Mm-hmm. What about the OSA?
The OSA, where is that?
Or obstructive sleep apnea. Sorry. Why is that important?
I'm not too sure.
Yeah, I don't know if it's that important in this case. What about let me see here. Do you think that the deep venous thrombosis is important?
It's currently being treated, so maybe I don't think it would be that important.
Yeah, so the only thing that I can think of that is going to be important with that is if, with the DVT, if he is having, if he's on an anticoagulant, so that's the rivaroxaban. If he has that, then maybe, so maybe he's going to be pouring more blood into his urine if he does have like a kidney stone. And so that's what, right now I'm a little iffy with the history, with that history. If he's not saying that he has blood in his urine and it's not super obvious, maybe it's not a kidney stone, although that's not diagnostic by any means. So yeah, and I think the rest of the history is not super important.
Yeah.
Okay, so that side. Okay, good. So let me see. So Dr. Iman, what else do you think is important there?
I'm not really too sure, but I was thinking maybe like some of his symptoms might be a side effect from like medications that he's taking.
Okay, so which ones?
Maybe nausea.
I think for what medication would cause nausea?
I don't really know like much about the medication, so I don't know like what they would cause.
Yeah, so metformin, when you just start it, it can cause some nausea, but this is probably a long-term medication for him. I think niacin maybe as well, but I'd have to look that up. I honestly don't really use niacin that often. Yeah, I think those are the main ones. He's on lisinopril, so that does work on the kidneys to help lower blood pressure. And so if his kidneys do appear injured, that's something we want to stop, but I don't think that's necessarily causing his symptoms. Mm-hmm. But yeah, the rivaroxaban along with the aspirin, those are anticoagulants or blood thinners. If he had trauma and he's now bleeding into that area, or his son hit his side and it injured his kidney, he might be having bleeding in that part, just because it's a little bit easier for him to bleed. So maybe direct trauma is one thing. But okay, good. Dr. Wilson, what else in the past medical history do you think is relevant? All right, let's see. Dr. Vinesh, what else do you think is more relevant?
I'd say his family history with his siblings having kidney stones.
Yeah, so if his family history has like people having kidney stones, then it's possible he's also going to have kidney stones. Although you don't necessarily need a family history of kidney stones to have kidney stones. So, but yeah, you're right. Anything else?
I don't know how would hypertension relate to like having the problem that he has right now with his mother and father having it.
Yeah, I mean, I don't think he already has high blood pressure, so I don't think that that's super relevant. I can't think of a reason why that would cause left lower abdominal pain. But okay. Anything else in the history in general? It doesn't have to be family history.
Let's see. we can rule out any type of like STI or anything because he only has unprotected sex with his wife.
Yeah. So so there are some sexually transmitted infections that can cause symptoms like he has. Typically, like if we're thinking pelvic inflammatory disease, that's going to be in a woman. But something like a prostatitis can cause pain like this. It's not usually left floor quadrant, but if somebody has like a chlamydia infection or even like a gonorrhea infection, or really any STI, it can cause inflammation of the prostate and in a male, and that can cause some pretty significant pain, especially when they urinate. And a lot of times you'll treat it with antibiotics thinking it's a UTI, and it doesn't. The symptoms mildly improve, but then it doesn't go away. They have continued symptoms, and so yeah, definitely a good point to bring up. His sexual history is going to be important to narrowing down things that are less likely. So good. All right. Anything else that anybody can think of?
I have a question. So why is he taking the niacin and I'm not sure how to pronounce it. It's like the rosuvastatin. Like those are both, like, they lower their cholesterol, but why is he taking two statins at the same time?
So the niacin is not actually a statin. It's a different category of medication. Rosuvastatin it works on one pathway. The niacin works on a separate pathway. I'm not super familiar with niacin, to be honest, just because I never really use it. I use the statins more so than anything. Studies show that statins have the best effect on cholesterol. When somebody has continued uncontrolled cholesterol, they can add these second agents like niacin or ezetimibe or there's other ones that I'm forgetting right now. But those work on different parts of the cholesterol profile. And so that's usually why they would do that. But like I said, I don't typically use niacin as often.
Thank you.
All right. I think we got everything on the past medical history. So let's go to the physical. All right. So he appears non-toxic, but seems uncomfortable on the exam bed. And then the vitals are there. So let anybody want to interpret those vitals? So let's go with Dr. Miller. If you are there, do you want to try to interpret those vitals? Okay, Dr. Niche, go for it.
Okay. So his temperature is 37 degrees Celsius, and since I can't do the mental math in my head, I converted it to Fahrenheit, and that's like 98.6, so that's fairly normal. His pulse is 99 beats per minute, so I guess that's mostly fine. That's pretty normal for his age. His BP is a little hypertensive, but that's consistent with his past medical history.
Okay.
His respirations are a little on the low side, but I guess that's not much of an issue right now, but that should probably be watched.
Okay.
His height and his weight, yeah, he's pretty tall, and but mostly his BMI is it's pretty large. His BMI is pretty excessive.
Yeah,
so that might cause some issues.
Exactly. So definitely the BMI is pretty high. So his BMI is 40. So he is severely obese. The respiratory rate 16 is normal. I wouldn't necessarily worry too much about that. The BP and the pulse, probably because he's in pain. So his pulse is almost tachycardic. So above 100 is what we consider tachycardia. and the blood pressure being 150/90. Maybe it's just his history of hypertension. Maybe he didn't take his meds, but he is elevated, or maybe he's just in general in pain. So temp being 37, yeah, like you said, it's not super relevant. It's normal. So that tells us maybe less likely a raging infection at this point. Yeah, good. So,
thank you.
Yeah, no problem. If he's taking medication that controls blood pressure, wouldn't having high blood pressure be a concern? Yeah, so Manassi's right. So when we, if his blood pressure is well controlled, then we have to look back at his records to see if his blood pressure is well controlled on the meds he's on. But that would tell us that there's something underlying if it is well controlled and he is now hypertensive. All right. So the skin exam is warm and dry to the touch, no rashes or lesions. And the general appearance is non-toxic, but seems uncomfortable on the exam bed. So non-toxic just means that he doesn't look very, very sick. Ear, nose, and throat is unremarkable. Pulmonary breath sounds present and equal bilaterally. No stridor rails or wheezing, so that's fine. Cardiovascular, regular rate and rhythm. No murmurs or rubs Radial and pedal pulse is present, equal bilaterally. No pedal edema. That's fine. All right, so GI. So somebody's gonna interpret this. So no ecchymoses. Bowel sounds normal in all quadrants. Abdomen non-distended, soft and non-tender to light and deep palpation. No guarding, rigidity, rebound, or masses. Negative Murphy sign. Rectal exam is heme negative. So, who wants to talk about that? All right, go for it, Dr. Hannah.
So basically, the no ecchymosis means that there's no discoloration under the skin that could possibly be from internal bleeding. So I know we kind of talked about that with getting hit by his son, if maybe he was having some bleeding, so we could kind of rule that out.
Okay.
The bowel sounds are normal in all quadrants, so I can rule out a bowel perforation. And he, from the start, said that he wasn't really having that many issues with passing bowel, and he had gone yesterday.
Yeah.
The abdomen, non-distended, soft and non-tender. There's no guarding, rigidity, rebound, or masses. So this kind of means that there's nothing under there that's causing him pain that's rebounding back when you touch it. And the negative Murphy sign rules out cholecystitis.
Okay.
The rectal exam is heme negative, meaning that he doesn't really have any blood in his stool.
Good. Yeah, so negative, so heme negative, not likely a GI bleed. The negative Murphy's, like you said, less likely cholecystitis or the inflammation of that gallbladder. Good mention of the no guarding, rigidity, or rebound, less likely peritoneal. Those are not peritoneal signs, so that means that the bowel is probably intact. He doesn't have any severe infection in the abdomen. He doesn't have any perforation of the bowel, most likely, or an appendicitis usually, especially when you're palpating in different parts of the belly and it looks he's not really having a lot of pain. That tells us that it's probably not the intestines per se, although that's not exactly diagnostic. So bowel sounds normal in all four quadrants. The only thing I would mention with what in addition to what you said is that's probably more indicative of not having an obstruction. So when you listen to it, and if there's an obstruction, you listen to it, you won't hear bowel sounds usually. And so that's what I get from that. And then no ecchymosis, like you said, he had the trauma, but it doesn't seem like it's severe enough to have either internal bleeding where you have that flank bruising, or superficial as well. All right, good. So GU exam is circumcised penis, bilateral descended testes, testicles, testes and epididymal bodies, non-tender to palpation, no CVA tenderness. All right, anybody want to take that one?
This is just another question, but if he's 300 pounds, could that contribute
to the pain that he's feeling in his lower left abdomen? Like all that weight, like pressing on like whatever pain he's feeling, could that like increase it?
So not really. It might make your abdominal exam harder because you're having to push through more tissue, and so it might be harder to feel for things. When you have a high BMI like that, and you are overweight or obese to that degree, you have a higher chance of having inguinal hernias or hernias in general, because that pressure in the abdomen is going to be higher, and you're going to have a higher chance of pushing through those muscle layers. So that's the one thing I would think about with like having that high BMI. Although it also increases his risk for atherosclerotic disease with the hypertension, diabetes, high cholesterol, the obesity. That will increase your risk of having like narrowing of the vessels. Maybe we can think of a mesenteric ischemia or ischemic colitis, but we would typically see some signs of that in the bowel and in the stool. A lot of times with an ischemic colitis, you'll have blood in the stool. So that's kind of like where I would go down the path of with the obesity and like his other comorbidities. And we didn't see a bulge, so it's less likely a hernia, if that makes sense.
Thank you.
Yeah. All right. So someone in YouTube said, did we rule out testicular torsion? So the exam that we got of the GU, who wants to interpret that? We can go if Dr. Gracie is on. Do you want to try to take a stab at that?
I'm on, but I'm honestly not really familiar with a lot of this.
It's okay. So let's go through it together then.
Okay.
All right. So the circumcised penis, probably not super important unless there was like some type of inflammation around like the head of the penis or something like that. The bilateral descended testes is what somebody on YouTube was saying. Did we rule out testicular torsion? A lot of times with torsion, the testicle, which is usually kind of up and down like this, will end up being more horizontal, because as it twists around itself on its blood supply, it'll start to be more horizontally lying, and it'll be higher up. So that wouldn't necessarily rule out testicular torsion, but that's one of the signs of torsion. So we want to pay attention to that. There is a test that you can do where you basically stroke the inner side of the thigh, and that causes the testes to ascend. And I'm blanking at the name of that reflex right now. But if they don't do that, that is one sign of a torsion. So I don't think that they didn't mention that here that we did that or not. So we can't rule it out necessarily, and we might want to consider an ultrasound if we have a high suspicion. But yeah, the testes and epididymal bodies are non-tender to palpation. So basically, the structures inside the scrotum, so the testicles, the epididymis, all those are non-tender. So probably not a inflammatory process right now. And then no costovertebral angle tenderness. So do you know what CVA tenderness means, or like what we do to test for CVA tenderness?
I feel like we've mentioned it, but I'm kind of blanking out right now.
It's okay. So what we do is we put our flat of the hand right on the back where the kidneys are, and basically what I do is I put my hand there and I tap really hard on the back. And if there is any type of inflammatory process within the kidney, like usually it's because of a pyelonephritis, so like an infection of the kidney, they will jump up in pain and try to push your hand away because it's so painful. And so the fact that we're not seeing that, he doesn't have CVA tenderness, probably not a kidney infection at this point. So That's generally what CVA tenderness means. There was a question. Oh, so Dr. Polito saying premasteric reflex. That's the name of the reflex I'm talking about, where you stroke the inner thigh and the testicles ascend. So good job. All right. So muscle strength is intact in all 4 limbs. No tenderness to palpation or with movement. So that's fine. And then alert and oriented to person, place, time, and event. So that's fine as well. So nothing super significant there. Anybody else want to talk about anything in the physical exam before we move on? No? Okay, cool. All right, let's go with our differential diagnoses. So at this time, which of the following differentials cannot be excluded based off of history and physical exam in this patient? All right, so the first one is appendicitis. Can we rule out appendicitis in this patient? So the people saying yes. Does somebody want to say why? Why can we rule it out?
I can say, isn't it on the opposite side of the body, because the appendix is on the right and he's having left pain in the flank area, left flank area, sorry.
Yeah, exactly. So the patient's having the left lower quadrant pain, so like pain down here, and the appendix is on the opposite side. So typically with appendicitis, you'll have pain to palpation right in that right lower quadrant, and it's, I forget the exact amount, but it's at McBurney's point usually. So it's between the belly button and the front part of your pelvis. There's a midpoint in between those two where the appendix usually lies. And so if they have pain to palpation there, we're usually worried about an appendicitis. In early appendicitis, you can have pain around the belly button, and that can be a symptom. In kids, they can have no pain and they just don't want to play and they are looking a little sick, and that can be the only signs of appendicitis they have. And that's why kids are scary, because if they rupture and you don't catch it, that can be really bad. So, all right. So probably not appendicitis. I wouldn't include that in my differential right now. Bowel obstruction. What do you guys think about that? So, is it possible? Dr. Manassi, what do you think?
So earlier it said that he had no constipation or diarrhea and that his bowel movements seemed normal, I think, in the physical examination test. So I feel like bowel obstruction would not be possible, or at least not likely.
Yeah, it's not super likely because he's having regular bowel movements. The last time he had a bowel movement, I think they said was like yesterday, and he's not with a bowel obstruction. You'll generally have a bunch of pain diffusely in the abdomen, and they'll be pretty distended. Although with a obese patient, it's hard to see that distension. So I would probably not include it in my differential as well. What about cholecystitis? Yeah, most people are saying no because there's no Murphy sign. We would expect the pain in the right upper quadrant. Yeah, so I probably wouldn't include that. What about colon cancer? Can we rule out colon cancer? Dr. Saya. Why can't we exclude colon cancer?
I think it was just because you said the weight loss and fatigue.
Okay, so yeah.
But he denies that, yeah.
Yeah, we can't necessarily rule it out because of that, but does colon cancer usually present with pain?
It's unlikely.
Yeah, I don't typically see colon cancer present with pain. Usually colon cancer is more insidious onset. It happens over a long period of time. You'll have, in older people, you'll have like this new onset constipation. You can have some blood in your stool, and those are the more typical signs along with the weight loss. They can have some other night sweats if it depending on the type of cancer. And then they usually will have some bowel changes as well. So they can have like thinner looking stools, we call like pencil thin stools or something like that. So yeah, I don't know if this would necessarily be colon cancer. I actually probably wouldn't include it in my differential. I don't know if they, yeah, I probably wouldn't include it. What about a dissecting aortic aneurysm? Included. Okay. Dr. Maha saying he doesn't have chest pain and he would have a lower BP. Not all the time. So, Dr. Zhang, you're saying that you should include it. Why?
I just thought that it's possible just because of the location of the pain is similar to where that usually presents. So, like, I don't think we should eliminate it completely yet, just in case it's like a rare case.
Yeah. So the aneurysm, so an aortic aneurysm, so the aorta basically starts on the heart, comes up, and then comes back down all the way down your abdomen. And it's in the back, and so that wouldn't necessarily cause pain when you're palpating, and he doesn't have pain when you're palpating. He doesn't have the typical like tearing type pain, although in the abdomen, I don't know if you'd have that same sensation. I don't know if, yeah, it's hard because if it's actively dissecting, I would think that, and you don't have to actually have low blood pressure either. I think I would agree with you that we can't eliminate it, but I don't know how likely it is. And they're saying cannot be excluded, so I would include it in our differential, but it would probably be really low. All right, what about diverticulitis? Thoughts about diverticulitis? Should we include it or shouldn't we? Yeah, I think we should include it. He's having left lower quadrant abdominal pain. Although he's actually pretty young. He was like 45. And then usually diverticulitis happens later after a long history of constipation. And he also said he wasn't constipated, so maybe not, but I don't think we can rule it out per se. Epididymitis. What do you guys think? Exclude, unlikely. Yeah, he doesn't have tenderness on the epididymis, so probably not. Gastroenteritis. Dr. Ono, what do you think?
So that would be inflammation of the stomach and the intestines, right?
Mm-hmm.
I would say include it only because he's having nausea, and I guess the pain is lower in the abdomen, so that would, I don't know.
Yeah, I was thinking about including it because of the nausea as well, but I don't know, because he has lower abdominal pain, and usually when you have lower cramping abdominal pain, it's because he's already having diarrhea and he hasn't had diarrhea.
Right.
Generally, gastroenteritis would cause more of a diffuse type pain,
Mm-hmm.
but I don't know if we can exclude it entirely. So I would. He's not vomiting; he's just nauseous.
Yeah.
I don't know. I leave it. I will leave this one up to you. You want to include it, or you don't want to include it?
I would probably include it.
Let's include it then. All right. We'll see. I'll ask you this the next one. What about ischemic colitis?
Yeah, I would probably include that one. Is that like bleeding of the colon, or?
Yeah. So it's basically what the name says. So colitis is just inflammation of the colon. Ischemic just means that there's not enough blood flow to the colon itself. So one of the hallmark signs of ischemic colitis is blood in the urine. I mean, in the stool. Sorry. And so they would usually have belly pain with that because the bowel's not getting as much blood flow, so they'll have tenderness in those areas. What do you think? Do you want to include it or not?
I would say no because there's no blood in the stool.
Yeah, I probably wouldn't include it also. There's no blood in the stool. Yeah. Okay. What about, Dr. Safer, nephrolithiasis, so a kidney stone. I'm pretty sure everybody's going to, include it. Good. So let's include that. What about pancreatitis? Dr. Haydari, why wouldn't you include pancreatitis?
I would expect pancreatic pain to be in the right upper quadrant, and he has pain in the left lower quadrant that radiates to the groin. And I think in pancreatitis, you might have like pain in the upper abdomen and also maybe in the back.
Yeah, typically for pancreatitis, I usually see it in the epigastric region, so like right in the middle upper part of the abdomen. It can be right upper quadrant as well, and it typically radiates to the back. So I probably wouldn't include it. A lot of times they're unable to eat as well, and I think they said that he was able to eat, so I wouldn't include it. Splenic laceration or contusion. What do you guys think? Oh, Dr. Hidari saying he had no appetite. That's true. He did have no appetite, and he had nausea for the pancreatitis. But I think that the location of the pain makes it less likely. So I would still keep it off. Okay. Dr. Chavez, you're saying yes to the splenic lac. Why? Okay. Dr. Shabi, why would you say yes to including the splenic laceration?
So he got hit on the left side, so the spleen is like really vascular, so it could be ruptured.
Yeah, so you can have a rupture of that's causing some blood to pour into the belly. The one reason I would say maybe less likely is because if he does have a significant bleed, he would probably have a lower blood pressure, and his blood pressure is high. Although if it's not a huge bleed and his body's trying to compensate and increase his blood pressure because he's losing volume, he might have a higher transient blood pressure that decreases over time. So I leave it up to you. Do you want to include it or you don't want to include it?
I could just include it.
Include it? All right, let's include it. All right, and then a UTI. What do you guys think? Out. Okay. So no. Yeah, he would typically have dysuria, so he'll have pain when he urinates. And he doesn't have that. He'd also probably have increased frequency. You can have pain in that general area without a fever. But it's not typically like with movement. So I don't know. I would probably say no. Yeah, I would probably say no. All right, so let's submit this. Let's see what we got wrong. All right, so appendicitis manifests with pain on the right side, likely to worsen rather than lessen with ambulation. So true. Oh, did he have pain that was better with walking? I thought it was worse with walking. Yeah, okay. So then I was thinking of the wrong thing. Bowel obstruction, although the pain due to bowel obstruction can be intermittent, it would not be localized. Nausea and vomiting would be more prominent, and some abdominal distension would be present, like we talked about, although it's harder to detect in obese patients. Yeah. All right. So cholecystitis, it's usually in the right upper quadrant. It can refer to the right shoulder, not really in the left lower quadrant or the groin area. Colon cancer, it rarely presents as abdominal pain. Dissecting aortic aneurysm. This is the one that I was unsure about. So the patient is young. A dissecting ruptured aortic aneurysm can cause left-sided abdominal pain and is a dangerous condition that should always be considered. Cool. Diverticulitis can cause pain in the left lower quadrant, and it can include nausea. Appendicitis usually will have scrotal pain, marked scrotal tenderness, and would typically have scrotal tenderness as well, so good. Gastroenteritis, although the nausea and abdominal discomfort are present in the patient with gastroenteritis, pain is typically generalized, and they would have significant vomiting and diarrhea. So yeah, yeah, I guess, because if they're already having that lower abdominal pain, it would probably be cramping because of, the diarrhea, and then generally in the onset, it's more like a diffuse type pain. So yeah, I agree with that. Ischemic colitis usually presents with bloody or heme-positive stools, and patients are typically older. Nephrolithiasis can cause severe intermittent pain extending from the left flank to the groin. So yeah, so that makes sense, and I think that's kind of what we are thinking about at this time. Pancreatitis is typically in the upper abdomen radiating to the back, not the groin. Splenic plaque. So although the mechanism of injury appeared minimal, the patient is at an increased risk of bleeding because he is taking an anticoagulant. So I forgot that he was on rivaroxaban. So splenic injury, which is a dangerous condition, should be considered. Yeah, I completely forgot that he was on rivaroxaban. But at the same time, he doesn't have the symptoms of a bleed into his belly. So it would be lower, but I think because he got hit, you still have to consider it. Okay, and then UTI. So we didn't include it, but they're saying although the patient is afebrile and has no dysuria, frequency, or urgency, the risk of having a UTI is increased because he has diabetes. Okay, I'll give him that. But his diabetes is well controlled, so I don't know if I would 100% agree with that. Yeah, I guess. Okay, fine. All right, let's go to the next page. So the next steps. So based off the history and physical exams, which of the following are the most appropriate steps to guide the diagnosis and treatment? So do you guys want to get an abdominal ultrasound? Yes. Okay. I would say probably not. Because, and the only reason I say because I wouldn't do that is because there's an option for a CT scan. So why would I want a CT versus an ultrasound? Does anybody know? CT can be faster, yeah. It is going to be a bit more accurate. It wouldn't cause injury to the kidneys. It's actually really safe study. There's no radiation involved with ultrasound. So, yeah, I think, yeah, Dr. Salman has what I was getting at. So he's obese. So when you have obese patients, it's very hard, not very hard, but it's harder to get a good picture on an ultrasound because you have to, those sound waves have to propagate through more tissue. And so a CT would probably be better. Yeah, so no to the abdominal ultrasound. Now the question is, do we want contrast or no contrast? Dr. Nassim, why would we want to do it without contrast?
Right. So you do it without contrast.
I'm sorry, what was that?
If there's potential injuries to the kidney, then the contrast, I remember you saying it's toxic to some extent. So that contrast, if we put it like in the kidneys, it can affect it even more, and we want to avoid that.
Yeah. So what Dr. Nassim was saying is that if we give contrast and the patient has a renal injury, you can potentially harm the kidney even more. Yeah, I agree with that. The other thing is we're kind of thinking of a kidney stone at this point, and so one thing that I wanted to kind of impress on you guys is when you order scans, you have to know what you're looking for. You don't typically just order a scan or a lab without knowing why we are ordering it. And so with the CT, if we're looking for a kidney stone, and I don't expect you guys to necessarily know this, you can get away with a non-contrast study because you're just looking for this a bright spot on the CT that shows that there's a stone somewhere in that tract. And so you don't necessarily need contrast for that because most stones will are pretty bright in general. The times that I use contrast is if I'm trying to evaluate for like infection or like malignancy. Those are the two that I really want to use contrast for. The rest, or if I'm trying to really get a good look at the bowels, I'd want to probably use contrast. And it would, if I'm looking for the bowel for bowel pathology, I would use oral contrast. So they drink the contrast agent and then they also put it through the veins, so we can really see the difference between the inside of the bowel and the outside. Okay, someone on YouTube said, can you also do a VQ mismatch? Typically, we do a VQ scan for pulmonary embolism, so probably not. I don't know. I don't think that we are considering pulmonary embolism in this situation. So, okay, so I would do it without contrast. All right, blood cultures. Do we want to get blood cultures on this patient? And why do we want to get blood cultures? So, for those who don't know, a blood culture is basically you draw blood and you send that blood out to a lab and they will plate it on certain plates and they'll see if bacteria grow out to see if you have bacteria in your blood. I would probably, he doesn't look septic or toxic, but there's a possibility of an infection, so I would probably get it. Although if I'm thinking of it from a resource perspective, it's probably not a great use of resources right now. If I wanted to give antibiotics to this guy, I would probably get a blood culture because you don't want to give antibiotics before you take a culture, because if there's some smaller amount of activity against the bacteria, it will make it harder for that bacteria to grow out. So I would include it. I don't know if it's exactly the right thing to do, but I would include it. What about a CBC? Yeah, so definitely we want to look to see if there's any inflammatory process. Also, if he's bleeding a lot, especially since he's on rivaroxaban, I would want to know if he is pouring blood into his GU tract, although we would probably see blood in there. So yeah, I would include it. What about a basic metabolic profile? Yeah. So we want to make sure that we take a good look at the kidneys and see if there's any type of injury there. So we talked about the CT abdomen with PO and IV contrast. We don't want that right now. X-rays of the abdomen. I probably wouldn't. Yeah, I wouldn't get an X-ray of the abdomen because it's not. If we're gonna get a CT, it's not gonna give us any more information. The one thing that I usually get a X-ray for of the abdomen is if I want them sitting upright, and I'm going to evaluate for air fluid levels to look for like a bowel obstruction. So if the bowels aren't moving, what ends up happening is that you have distension of the bowel, and then you have these layering of air fluid levels, basically, where the fluid's kind of just sitting down, and you see these like straight lines across. And after this case, if you guys want to see some of that radiology, I can pull up some images on Google and we can look at that. So urine culture, I think some people said, yeah, they want a culture. I definitely would want to get a culture and a urinalysis because I want to evaluate for an infection. I want to make sure that see if there's any bleeding there or anything like that. So yes to both of those. All right, let's see what they said. Ultrasound less sensitive than other imaging, so like we talked about, and the patient is markedly obese. Blood cultures, the patient is afebrile and without signs of infection, so culture should not be done. Yeah, that was me being just overly cautious. Okay. CBC, although not routinely useful in evaluation of abdominal pain, CBC is done at the time to check for subclinical infection and hemorrhage. So yes, so bleeding and infection. BMP is done because the patient is diabetic and it's reasonable to assess his blood glucose level. Yeah, I guess that's true. Electrolyte concentrations, I guess that's true too. I would honestly just want it for more so for the renal function. CT of the abdomen is useful. Contrast is not always necessary initially, and at this point should be used if the diagnosis is not clear after the scan is done without contrast. So, yeah, I agree with that. CT of the abdomen and pelvis without contrast. So we did want this. So a CT scan without contrast can detect or exclude several diagnostic possibilities in this patient and can be done more rapidly than a scan without contrast. And they're saying if we need the contrast, we can get it done afterwards. So that was what we thought too. Abdominal X-rays have poor sensitivity, and most of the causes, possible causes of this patient's symptoms. So, okay. Urine culture is important to exclude UTI because the patient is diabetic, and then the UA is a simple screening test that can detect hematuria, so blood in the urine, and markers of infection that will help narrow down the diagnostic possibilities. So, definitely. So the only one that we got wrong was the one that I wanted to do but was not super excited about, so that's okay. All right. So the test results. So his UA has a pH of 5.8, specific gravity 1.01. He has blood in the urine, and he has not many WBCs, no leukocyte esterase, no nitrites, no bacteria. So anybody want to interpret that UA for me? Let's go with Dr. Abdul Shafi. Do you want to try that?
I'm not really sure.
It's okay. We can go through it together. So the pH, I actually don't know the reference range for the pH, so I don't know what to make of that. I probably wouldn't. I wouldn't pay any mind to that. So specific gravity tells us how concentrated the urine is. His is in the appropriate reference range, so I don't think he's dehydrated per se. RBC, so he has blood in the urine. So it says 20 to 25 per high power field. So that's a good amount of blood in there. So what would you be thinking with that blood?
Maybe UTI?
Maybe a UTI. What else are we thinking of? Or before you talk about that, why is it less likely a UTI if you look at the rest of the UA?
Oh, because there's no bacteria?
There's no bacteria. The nitrites, which is a breakdown product of that the gram-negative bacteria in the urine do, that is negative also. Leukocyte esterase is a sign of inflammation in the bladder and in the urinary tract, and so that's negative as well. And then there's no white blood cells, which typically will respond to an infection or inflammation. So less likely a UTI, but what else can have blood in the urine?
They probably have like a kidney stone or something wrong with their kidneys.
A kidney stone, exactly. If you have a kidney injury from like trauma and it's pouring blood into the actual GU tract itself, that can also cause some blood. So good job. All right, hemoglobin is 14, white blood cell count is 5, and platelets are 150. So anybody want to try that one? Let's go with Dr. Girgis. Do you want to try that one?
I'm sorry. I didn't really go through the CBC slides that well, so.
No, it's okay. So I can tell you right now, it looks pretty good to me. So there's not really much to see there. So the hemoglobin looks normal, the white blood cell count looks normal, and the platelet count looks normal. Why is it important? The hemoglobin was 14, the white blood cell count was 5, and the platelet count was 150. So why is it important that the let's focus on the WBC. Why is it important to know that it's normal?
Just to make sure also that there's no infection and no inflammation.
Yeah, so it kind of helps us rule out a severe infection. So, good. All right, do you want to try the metabolic panel?
It's okay. Someone else could do it.
Okay. All right. Who else? Who wants to try the metabolic panel? Dr. Vivian, you want to try it? All right, let's Dr. Yasmin. What does it look like to you?
Well, I think sodium, potassium, and creatinine are pretty much within the range, but then glucose is like a little high, but it's not too much of a concern.
It depends on if he's fasting or not. I think the glucose is okay. It's not anything I'd get too worried about. With the glucose, I'd be more worried if it's like super, super high, like 400, 500, 600. Or if it's like super low, like 40, 50. Yeah, so the most important thing in this is the creatinine. So the creatinine of 0.7 is normal. So that tells us that whatever's happening is not really affecting the kidneys right now. So good job. All right.
Yeah.
Okay, so we have CT scans. Cool. I can go over some radiology. All right, so looking at this first scan, I don't know how well you can see it on the screen, but does anybody want to tell me what they see in the CT scan? And I can help orient you if you want. And if nobody wants to, that's okay. I can read it. I can read the scan for you. I see the kidneys, I think. Okay, so I'll go through it. All right. So this, all right. So right here, it's probably really hard to see. This is an R, so that tells you this is the right side. This is the left side. Oh, okay. So Dr. Selena, go for it.
Hello, can you hear me?
Yeah.
Okay, so I don't know anything about this, but I'm gonna try.
Go for it.
So at the very bottom, I'm not sure, but is this the left and right lungs?
So here, no, this right here are muscles. So you want to always orient yourself. So right here is the spinal column, right? So this is the front of the spinal column. So those are the big round bones. This is the back, and then this right here is the spinal cord itself. So behind that is going to be your back muscles.
Okay.
And then so these little white things right here, those are part of your rib. So it's taking it at a cross section, right? So you're cutting the body this way. And so you're looking at it as if you're looking at somebody's feet and looking up towards their head. So we're probably about the level, these right here are your kidneys. So we're about at the level of the kidneys. So that's going to be about like right there.
Okay.
Okay. So. Okay. All right, so what are these things right here?
Those two, aren't those the kidneys?
Those are your kidneys. Over here, what's on the right side that kind of is near the kidney?
The liver.
The liver, good. And all these little circly thingies that are in here, what does that look like? What do you think those are?
Can it be I'm not sure if it's the intestines?
Yeah, those are your bowels.
Okay.
So the ones that are kind of having these like dark circles in them, and it looks like they're like little smaller dark circles in there. Those are probably your larger intestines. And do you know what all of this is that we're looking at?
Is it the mesentery?
No, that's just poop.
Oh.
Yeah. So these little kind of like black dots in there, those are like air pockets within the poop itself. And so that's
okay.
Okay. So the darker ones in here, those are probably your smaller intestine. Okay. Okay, so we have intestine over here. We have liver over here. And we have kidneys here. So this CT, this slide of the CT scan is I think trying to show us one specific thing, and it's this right here. So what do you think that is? And why is it present on this side?
Is it like a mass building up within the kidneys, like an obstruction or something like that?
So kidney stones a lot of times are made out of calcium, and so what else in our body has a lot of calcium in it?
The bones.
The bones, right? How do the bones look on the CT scan? Like what color is it?
Oh, they're white.
They're white, right? They're really white. So this is probably not a stone. What this is the where the urine starts pouring out. So that's the renal pelvis going into the ureters. So the kidneys are like this. Probably this is a good way of putting it. It's like C-shaped organ that drains out into kind of like this triangle-shaped cone, and it becomes a tube going down into the into eventually hit the bladder. And so on the right side here, it doesn't look like they have that same pattern as on the left, and so that tells me that there's probably some dilation on the left side versus the right, where we don't really see it. The right is what I would call more typical. The left side looks dilated to me, and so that's what I would call. Dr. Safe is saying maybe it's inflamed. Inflammation usually around the kidney will kind of look like a streaky type pattern, and I don't necessarily see that. If I do see it, I will show it to you, or we can probably pull up some images afterwards. So like what a pyelonephritis will look like. All right, so let's
And
go
then
to the
just
next.
a quick question.
Yeah.
Sorry.
No,
So how does the calcium deposit there? Guess.
You're asking if there's a calcium deposit there?
Mm-hmm.
I don't see one. So I don't think there's a calcium deposit in there. You're talking about in here?
Okay. Yes. How would you know looking at a scan if you had for example like nephrocalcinosis or anything like that?
Yeah, so nephrocalcinosis is basically just mineralization of the kidney. It causes a lot of destruction of the kidney, and so the kidney will look really like bright and white, and you'll see a lot of mineral deposition in there. So if you want, I can pull up a picture after this, and we can take a look of what nephrocalcinosis would look like and compare it to this. But you would see typically your kidney be really bright, like the bones look.
Okay, thank you.
Yeah. Do you want to try the next one, or you want to give it to somebody else?
I can give it to someone else.
Okay. So this is the next one. Who wants to try to read that? All right, Dr. Nassim, go for it.
Okay, so I think so I see like it's showing like the right side. So are we looking from like now we're looking as if we're looking from the head rather than the feet? Like
No, so whenever we do a CT scan, we always look from the feet to the head. So as we scroll down on the CT scan, we're just getting different slices, but we're always looking from the feet, looking at the feet going towards the head. So orient yourself. Where do you think we are in the body?
I think maybe we're towards, I want to say more towards like the upper body. So, because I feel like that all that white stuff is their ribs, right? Like those are the ribs.
No. So the ribs. So if we look at this one, this is typically what ribs look like on a cross section, because we're only getting part of the ribs as we go down, and so we only see these little like slivers of rib because we're cutting it along the side of the rib, and so the ribs are angled downwards like this as they come from the back and hitting the sternum. And so we don't see a flat rib like that. The ribs are more this way, so you're only getting a certain slice of it as we go down. So this is what ribs look like in general. Here you're talking about the bones, right?
Oh, the comments are saying like the pelvic area.
Yeah, so this right here is probably the sacrum, and then this is your pelvis. So if you feel your own pelvic bones, I don't know if you're going to be able to see. The pelvis is kind of like this winged, yeah, you guys can't see. Sorry. It's kind of like this, like cup almost. And then in the back of it, you have your sacrum, which is kind of like a little C cupped this way, and then you have the rest of your pelvis like that. And so if you look at it and you look at the scan, it kind of looks like a bowl, right? You don't see it here because we're probably not getting that part of the pelvis, but it looks kind of like a bowl shape here. And that's typically what the pelvis would look like. So these are your pelvic bones, and then this is your sacrum. I think most likely that's part of your sacrum. Does that make sense?
Yes.
Okay. So behind that, that's going to be all of your pelvic muscles, so like your glutes and your back muscles. And then on the inside, what are these things that we talked about before?
The small intestines, I believe.
Yeah, small intestine versus large intestine. You see the poop in there. And then this looks like muscle. What else do you see in here?
Does like I don't know if it's like important, probably not, but like that large black like area, is that important, or is that just
This right here?
Yeah.
Yeah, so that's just like your mesentery. So that's just the filler between all the intestines and organs. So you will see a lot of that on scans. The more obese somebody is, the more you're gonna have that filler type stuff in there. So yeah, what else? What else do you see in there?
The comments are saying that the white dot on like the left side, maybe it's a stone.
Yeah. So there's a bright white dot here that's not present on the other side. So, and it looks pretty similar to color of the bones. And so yeah, that looks like a stone. And where's this stone?
Oh my gosh, is it maybe like, well, kidney stones, can they be in arteries? Is that possible?
Not arteries. It's in the urinary tract. So you have the kidneys that drain into the ureters, and the ureters take all of that urine down into the bladder. So where are we looking at right here? What do you think that this is?
So it would be the ureter? Then?
Yeah, the ureter. So we're going in, this is the left ureter here. It's going to eventually drain into the bladder. So this looks like a kidney stone. Good. You want to try the next one, or you want to give it to somebody else?
I can give it to someone else.
Okay. All right. Who wants to try it? All right. So Dr. Sammy, go for it.
Okay. So this kind of looks like we were in just looking at the top of the stomach type area, like just above like your pelvic region into the
Yeah.
You see like the liver and the kidney stuff and
So
spinal
yeah, so
cord.
the first two scans were cut this way. The last scan is actually cut this way, from the top down. So we're looking at it from the other side, so looking onto the patient. And so let's orient ourselves. So what's this over here?
The liver.
That's your liver. What about this?
Is that your pancreas?
What was that?
Is that your pancreas? No. I don't know.
So what's on the left side? So it's not your stomach. I can give you that. What else is there?
Your spleen?
Your spleen. So yeah, that's your spleen. These right here are muscles. You have your spinal cord back here. I mean your spinal column here. So you know you're kind of more towards the back.
Mhm.
What are these?
Kidneys.
Those are your kidneys. This
Your
is
pelvic bone.
your pelvic bone. So this is your
That's gonna be the head of your femur, right?
ilium, and this is the head of your femur. Good job. what is this right here?
So, would that be your bladder?
I'm not sure. I think this right here is his bladder. I'm thinking this might be his prostate.
Okay.
Which looks really big for a prostate. I'm probably reading this wrong, but that's what it kind of looks like.
Mm-hmm.
All right. So we know kind of where we are. What do you see here?
So I see 2 white dots kind of just above his, there's a white dot above his bladder, kind of, just right there, yeah.
Uh-huh.
And then just below, like what you called his prostate, there's 2 visible white, kind of.
These right here?
Yeah.
That's part of his bones. So
Okay.
these aren't stones.
Okay, and then I'm assuming those white dots along the sides are his ribs.
Yes, these are his ribs. Good job.
So the only thing that I can notice is that white dot right just to the right of his bladder prostate area, right by the muscle.
Exactly. So, and then if you look right above it, that's probably his ureter. So his ureter is coming down. He has this bright white dot right there. So that's the kidney stone, right? It hasn't gone into the bladder yet, so it's probably making its way down. And the only other thing I would want to show you guys is if you look here, this is the renal pelvis. This is what it drains out to. It looks a little bit bigger on the left side than it does on the right. Right. So this right here, you don't really see any. You don't see it as distended as you do here. So he is having. It looks like he is having some backup of urine into that area. Does that make sense?
Yeah.
So Dr. Monik is asking what is above his bladder. If you're talking about this, you see kind of like that speckled appearance, those little black dots. That's his intestine. Which also, maybe this isn't his prostate. Maybe this is his colon coming out, or the rectum. I don't know. That part's confusing. But the more important thing is this white dot right there that looks like a kidney stone. All right. So at this time, what's the most likely diagnosis? I mean, I'm sure everybody, stones. Kidney stones, exactly. So this is probably ureteral lithiasis. So stones in the urethra. So it's not a dissecting aortic aneurysm. It's not diverticulitis. He doesn't have any blood in the abdomen, so it's not likely a splenic laceration or contusion. And it's not likely a UTI because we see stones. So, yep. So the CT scan shows a 6 millimeter density with similar appearance to bone and a decompressed ureter that is past the density and a ureteral dilation proximately. So the image findings, along with the presence of hematuria and colicky nature of the pain, suggest a kidney stone is causing the patient's symptoms. So the decompressed ureter, I didn't typically focus on, but above that we saw it was dilated. So likely a kidney stone, and we saw the stone there. So how would the CT have been different if it was with contrast? You probably, it would be the same, most likely. You would just see a little bit more of the vessels around the area. So dissecting aortic aneurysm, it should be apparent on the CT scan. Contrast may be needed to rule out dissecting aneurysm. All right, diverticulitis, there's no sign of diverticulitis on the CT scan, although contrast scan might be needed to rule out a small area of diverticulitis. It is unlikely in the presence of plausible alternative diagnosis, especially given the normal white blood cell count. A splenic plaque, no free fluid was evident on the CT scan, which would be your blood, like on the CT, and the patient's hemoglobin level is normal, suggesting the patient does not have a splenic injury. Makes sense, right? And then UTI, UA was negative for infection, so it's not a UTI. Cool. All right, treatment. And I think we're almost done-ish. So at this time, which of the following are the most important appropriate management steps? So do you want to admit this guy to the hospital? Anish is saying yes. So yes or no. So if who wants to admit, and why would you want to admit them? You can just speak up.
Remove the stone.
How would you do that?
I don't know exactly, but I'm assuming isn't there some sort of way to break down the stone into smaller pieces till he's able to pass it?
Yeah, so that's something like shockwave lithotripsy, where you're basically using those waves to kind of break down the stone. We typically would do that with a big stone that's likely not going to pass. So I probably wouldn't do that. In all honesty, we don't need to actually admit this patient. I think, at least, because his vitals are stable. He doesn't have any signs or symptoms of infection. He's just in a lot of pain. So if we can control his pain, and his nausea too, if we can do those two things, I don't think he needs to stay here in the hospital. So I would probably just discharge him from the emergency department with a urine strainer. So basically, you're going to pee in a strainer, and it's going to try to catch stones as they come out, so we know when those stones come out. So I would probably do that one. So someone on YouTube is saying admits to the hospital and use a stent to remove the kidney stone. I would use a stent if they have recurrent stones, or if they have stones in the renal pelvis that haven't come down yet, and we need to ensure that is going to maintain open. So, what qualifies as a big stone? I believe over 1 centimeter is considered big. So I have to double check that though. If I'm remembering right, I think it's 1 centimeter. Percutaneous nephrolithotomy. So that means going through and basically taking out that stone. But nephrolithotomy is making me think that you're going to take it out from the kidney itself. The patient doesn't have a kidney stone. He has a ureteral stone. So I wouldn't want to do that. Could it still be a kidney stone if there weren't stones on the CT? And how would you diagnose kidney stones if it wasn't shown? I think there are types of stones that don't show on CT scans as well. I have to think back. An ultrasound would be better in that regard. But I'd have to double check that, because I know that there are stones that don't show up on X-ray, and that's why X-ray usually isn't as good. But I think you can still see those those stones that aren't super bright. I think you're still able to kind of see them. So I'd have to double check with that. Stents are a less invasive procedure, but I know it's usually applied for heart-related issues. I don't know if it would be so you do use stents in for kidney stones or for like obstructions like that. So what they do is they go in through the urethra up into the bladder, and so they use a scope for that, and then they snake the stent up those ureters to keep them opened up. So you would use a stent, but this case is probably not needed at this time. All right. Uteroscopic stone removal, that's using a scope to go in, like I said right now, and try to remove that stone. I think the stone is small enough that it'll pass on its own. We already talked about shockwave lithotripsy. Normal saline, 1 liter over 1 hour. So we're giving him a ton of fluids. Or not a ton, we're giving him fluids. Would you guys want to do that? Give this guy fluids? Yes. No. We're not admitting him. I'm conflicted, because you can give him fluids, especially if he's dehydrated, he's been vomiting, but we know he's not vomiting. We can see if he tolerates oral fluids, and then if he doesn't, we can give him IV. So I probably wouldn't give it right away, although if we give him fluids, it'll help push that stone along. But at the same time as well, his urine didn't look super concentrated, so he's probably not dehydrated. I would probably do oral for now. Yeah, I agree with you guys. We'd probably do oral, if anything. what is the normal elapsed time for a stone to pass? And say it doesn't, what should be done then? Since it's a small stone. I don't know that. I'd have to look it up. Typically, if they're having continued pain at the follow-up visit, like a week down the line or a few days down the line, so like I would probably say 3-5-ish days. Or if it's getting worse, I would consider doing additional studies. But at the same time, it's small enough where I think the studies have shown that it will pass on its own. It might just take some time. So I'd have to look up the criteria for that, though, to be honest. Okay. Ciprofloxacin, 500 milligrams PO BID for 10 days. Do you want to give antibiotics for this patient? Yeah, no, I wouldn't either. It's not, he doesn't have any signs or symptoms of infection, so I probably wouldn't want to do that. And then Ketorolac, it's a anti-inflammatory medication. It's kind of like ibuprofen, but a bit stronger. Would you want to give an anti-inflammatory? Yes, no, no, yes, no, no. I actually would. He doesn't have any signs of kidney damage, so I think it's okay to give an NSAID like this. Dr. Nassim is asking if we can give Tylenol instead. You can, but that's not an option. So I would probably give the Ketorolac. What about Zofran or Ondansetron? It's for nausea. Would you want to give that? Yeah. And then Oxy. Do you guys want to give oxycodone? No? Yeah, I wouldn't want to give oxycodone either. Especially scheduled oxycodone, I wouldn't want to give. So, all right, we got them all right. So, patients with renal colic are typically admitted when there's an infection or when their pain can't be controlled. And there's no signs of infection, and we haven't even tried pain medication. So the reason why we want to admit them if they have any signs of infection is because patients with a urinary tract infection that have stones can decompensate very, very quickly. And so if you see like an obstructing stone, they look sick, you want to call urology right away to take care of that, because they can decompensate and potentially die very quickly. Discharged from the emergency department with urine strainer. So the patient has a small, less than 1 centimeter distal stone, which has a good chance of passing without surgical intervention and should be collected in a strainer for testing. So, yeah. Percutaneous nephrolithotomy. So there is no, I guess, need for emergency treatment for this patient, we should give him a chance to pass the stone. Uteroscopic stone removal. It's effective for distal stones, which is what I think this patient has. So stones near the exit point, basically. And we should give him a chance to pass it spontaneously. Shockwave lithotripsy. I keep forgetting he's on anticoagulants. So he's currently taking anticoagulants, which is a contraindication for shockwave lithotripsy. And it's more effective for stones located in the distal ureter. Why do kidney stones need to be collected for testing? What can they be an indicator for in the body once they're tested? So it's based on the type of stone they have, you can change the treatment for it. And so something like is it a uric acid stone? You can change the pH of the urine, and it will you'll be able to pass it because it will dissolve the stone. Other stones like calcium oxalate or what is the other names of the stones? So it's like damn it, I forget. So based off of those the types of stones, you have different risk factors that cause the stone itself. So yeah, that's why you want to do it. So oxycodone, it shouldn't be given continually for a week. You want to make sure that you limit the amount of narcotics you give. Zofran or Ondansetron can help with the nausea. NSAIDs are effective and non-sedating, so that's why Ketorolac was indicated. no Cipro because there's no evidence of an infection, and then normal saline. So fluid loading, oral or IV, has not been shown to improve passage of renal stones. Cool. All right. Statistically, what is the most likely composition of the patient's ureteral stone? I don't expect you guys to know this, but can you guys give a guess? So calcium oxalate, calcium phosphate, cysteine, magnesium, ammonium phosphate, or struvite stone, or uric acid. Yeah, I think it's calcium oxalate. Yep, calcium oxalate. Which of the following is the only stone type that can be realistically dissolved, thus eliminate the need for surgical intervention? I just talked about this. So what type of stone? Anika said coconut oxalate. The big kid. Uric acid is the one that it's you can change the pH, I think. Yeah. You can change the pH for uric acid stones and it'll dissolve. In addition to oral pain medications, which other drug can be prescribed for a patient undergoing a trial of medical expulsive therapy for a ureteral stone? So this is like you're using medications to help pee the stone out. So dutasteride, finasteride, hydrochlorothiazide, or Zofran, or ondansetron. Finasteride and dutasteride are both medications that help with benign prostatic hyperplasia, just basically enlargement of the prostate. Well, actually, the prostate might have been big in this one, but I'm not actually sure if that was a prostate. So, but it's not going to really help with the immediate expulsion of the stone. Hydrochlorothiazide is a type of diuretic that we usually use for high blood pressure. It's not going to help push the stone out faster. So for me, I think it's Zofran is the right answer. So ondansetron to help them not be as nauseous. But I don't know if this is a great question. Yeah, so that's right. Which of the following urinary characteristics increase the risk of formation of stones in the urinary tract? I have no idea. Do you guys know? So hyperglycosuria, hypocalciuria, hypocitriuria. I don't know. High blood sugar, low calcium in the urine, low citrate in the urine, low oxalate in the urine, or low uricosauria. I have no idea what that is. Or a concentrated urine. I'm going to go with, let's see what you guys have. Hypocalciuria. Let's go with that. Nope. It is, wait. Oh, it's hypocitriuria. Cool. All right. So about the case. So the prevalence of ureteral stones in the U.S. Is approaching 12%, with slightly higher rates in men versus women. Symptoms can include flank pain, so that's that side pain over here, nausea, vomiting, urinary complaints such as blood in the urine, so hematuria, dysuria, so pain when you urinate, or urinary frequency, just peeing more frequently. If stones are present in the setting of a UTI, patients can present with fevers and chills, and if not treated early, progress to hemodynamic compromise. So they become super unstable, is what they're saying. Stable, comfortable patients with small stones, so less than a centimeter, should be offered outpatient expulsive therapy with oral alpha blocker. So that's something like Flomax. That helps them pee more, basically, is what it is. Pain medication, so like Ketorolac, NSAIDs like ibuprofen, naproxen. If it's very severe, you can give a short course of narcotic medications. And a urinary strainer to catch that stone. Follow-up should be scheduled for 4 to 6 weeks. Okay, from discharge from the emergency department. The patient being managed as an outpatient should be taught about warning signs that indicate the need for immediate follow-up. So that's fevers, uncontrolled pain, or inability to eat or drink. Ideally, the stone should be analyzed to help guide recommendations for stone prevention. So that's what we were talking about earlier. So stones are collected for analysis by instructing the patients to strain their urine during medical explosive therapy, or if surgery is required, by the urologist. So they'll take the stone and send it for analysis. In patients with risk factors or multiple episodes of nephrolithiasis, the urologic workup should be more detailed to help provide specific recommendations. Drinking 8 to 10 glasses of water per day is generally recommended to help reduce the formation of all stone types. Cool. So it was a kidney stone. All right. So what questions do you guys have for me? This one, I don't feel was as complicated as the pregnancy one. I actually enjoyed the pregnancy one a bit more. Although this one had good imaging, so it was kind of fun to go through the imaging with you guys. Any questions that you have? Nope. Okay. So, what caused the kidney stone? I don't know. Sometimes people just get so having being dehydrated increases your risk of having kidney stones. Elevated calcium will that you pee out will increase your risk. So, so there are some medications that will increase the concentration of calcium in the urine that increases your risk of stones. So yeah, so I'm forgetting some, but there are other causes as well. Did you guys want to see some of those scans that we talked about? All right. So I know nephrocalcinosis was one of them, but I don't know about the other ones. All right. So, can you guys still see the screen? All right, cool. So on an X-ray, this is what nephrocalcinosis will look like. Your kidneys will light up because there's a lot of calcium deposit in it, and so this destroys the kidneys. And on a CT scan, this is what it looks like. So you have a bunch of white dots within the kidney itself. So what else was it that we were going to go over? I forget what else I said. Let me look up. How do you treat nephrocalcinosis? That's something I have to look up. It's so incredibly rare that I don't know. It's not something we see commonly. I think a lot of these patients will go into renal failure and need dialysis, and I think the treatment is might be renal transplant, but I'm not 100% sure. I'm like 50% sure with that. I'd have to look it up. What else did you guys want to see? I had a patient that came in looking really, really sick, that had fevers, chills, pain with urination. She had really uncontrolled diabetes and ended up having needing to go to the ICU. And she had a urine infection, but it went up to her kidneys and caused pyelonephritis. Usually pyelonephritis, you don't need admission to the ICU for that. But the reason she did is because she had something called emphysematous pyelonephritis. So this is, let me look it up, emphysematous pyelo. Let me see here. This is a good example of it. So this is your kidney. So this is one kidney. This is the other kidney. Black on a CT scan is generally air. So this right here is air inside the kidney. So the bacteria proliferate and grow so fast that they produce air in the kidney and they destroy the kidney itself. And so patients will get very sick very quick. They'll end up in septic shock. They'll need pressors and fluids and all this stuff. And so the treatment for this, if it's this bad, is taking out the kidney. this kidney over here looks like it might be headed that way too. So, oh, and then contrast versus no contrast on a CT. Let's say kidney, since we're looking at the kidneys right now. Why isn't it going? All right. While I figure that out. Oh, okay, cool. All right. Here's a good example. So this is a non-contrast CT. So everything kind of looks dark here. There's nothing really lighting up except for the bones. But when we look at this side, the kidney's starting to light up a bit more because it gets a lot of blood flow. You have over here, you don't see like the aorta. Here, I think that's the aorta right there, so basically it lights up those blood vessels a bit more. So that's the main difference between CT without contrast and CT with contrast. So you see a little bit more detail there. All right. Are the rounds going to be the same format from now on? I didn't want them to be, but with the time that I have, I might actually, next week it might be another case like this, just because I don't have enough time on medicine to write up cases and make all the materials for you guys. So I'm sorry, but I feel like this is probably in transplants. I don't know. I actually didn't know they leave the old kidney in transplants. I'd have to look that up. There's a lot I have to look up, apparently, after this session. These lessons will always be why I tell my mom TikTok is important. Yeah, I agree. The format's good too. Extremely helpful. You guys are welcome. So I think nephrolithiasis is when you see the white stones on kidney scan. So is nephrocalcinosis having white stones or in the kidneys not being leveled? Not even. I'm not sure what the question was, but nephrocalcinosis is like within the actual kidney tissue itself, you'll have these white deposits, and not in the tract where the urine comes out. So that's the difference between the two. So nephrolithiasis is stones in the urinary tract. It can still be kind of in the kidney area, but they should be outside of the kidney tissue itself. And so once you have the kidney tissue being white and lit up like that, that's more likely nephrocalcinosis. All right. If there's any more questions, is there any more questions? If not, I will let you guys go.
I actually have a question.
What's up?
So I was wondering, so if this patient presented to the emergency department, would you guys work on this case as a group, or would it be one doctor working on the case, if you know what I mean?
Yeah, so something like this, you're meaning if we need a specialist to help us out?
Yeah.
Or yeah, no. So in the ER, there are a lot of things that myself as a non-specialist will take care of. It's only so for me, my philosophy is I take care of everything I can until I need help. So if it's a very complicated case where I don't know what's going on, I will call specialists for that. But for the most part, I actually call specialists more when I need something done. So if I need this patient to have dialysis, I'll call the nephrologist. If I need to have the cardiologist take a patient for a heart scan, so a stress test or a catheterization, that's when I'll call a cardiologist. Pulmonology, if I want to have the patient bronchhed, so put a scope down the throat and into the lungs and to evaluate the inside of the lungs. Stuff like that, where we kind of know what we need to do, but we ourselves as non-specialists can't do it because we're not really trained in that. That's when I would call. So for this patient that we're talking about, I would let's say the patient was really sick, they were septic, their blood pressure was low, we have a stone, it looks like they have an infection, we're thinking urosepsis, and the patient is crashing. I would call the urologist, be like, hey, this guy's doing really poorly, we need your help here. They'll come in, they'll scope them, they'll try to remove that stone, or they'll put a stent in, or they'll put a drain in, any one of those things. And so those are the things that I can't do myself, but I would need help for, if that makes sense. Hopefully that answers your question.
Yeah, that does answer my question. Thank you.
Okay. Dr. Abdul Shafi saying, I noticed the CT scans weren't level. One kidney was higher than the other. So people's anatomies are different. So one will be a little bit higher than the other. So if you think of the anatomy on the right side, the liver's there, so there's more things taking up that space. So I think the right kidney is usually a little bit lower than the left. I'd have to look that up to see, but yeah. I have a med school question. Would being a farm tech be considered healthcare experience, even if it's in the retail setting? Yes. So my approach for clinical experiences has always been more of like, do you get to talk to patients? Do you get to understand kind of like where they're coming from? And that's how I approach it. Some schools would be more of like a purist standpoint of, are you working directly with patients and on a medical side? So they might not consider it as clinical experience. In the end, I think that whether you put it as clinical or non-clinical is not a huge deal because the categorizations, I don't know how important they are. I wouldn't put like reading to kids in a library as clinical experience, but if it has something kind of related to, clinical experience and you put it in there, I don't think they're going to say, wow, they didn't categorize this right. They're not going to come into this med school, if that makes sense. All right. Any other questions? All right. If not, thank you guys. I had a lot of fun. Hope you guys had fun too. We'll probably keep this format for the next session, and it'll actually be the last session, most likely. And then from there, I'll kind of think about how I'm going to move this forward, and then we'll open it up again. We're probably going to have smaller classes, and it'll probably be on a 6-week rotation. So if you do want to join up again, definitely fill out the waitlist form. Keep an eye on the YouTube channel because we'll have more of these sessions where it's open for everybody. And then you guys let me know if you have any other input on what you want to do. So the waitlist form is going to be on my on my Instagram, on my TikTok. There is a link tree, and so I'm putting all of the links that I have that I'm things I'm putting together, resources, all that stuff, one-on-one mentoring. It's all going to be in that link tree. So there's one spot that you can go to look at all the things that I'm doing. So just look there and you'll see it. So will the cases be the same again? Some of them will be. And so that's why I don't know how useful it would be for somebody to come back and do it again. I'm trying to think of whether or not I want to use the same cases or different ones. I think a lot of the materials are going to be the same. Maybe the quiz is going to be the same. I might change it. So short answer, I don't know. I'm still trying to plan that out and figure that out. But I will try to do that probably next week, at the end of next week. So yeah. Any other questions? If you need any help for the next, if you guys want to help out, I'll probably send out an email asking like if you want to help and what you can help with. And so eventually I want to build a team around this and have people help me out with it. But I just have to really figure out exactly what it is that I want to do and how it's going to be structured so that I make sure that you guys are doing something productive. I don't want to just have you sitting there and not do anything. Somebody asked if you think clinical suicide hotline worker is clinical. I mean, I think so. You're talking to people about, their mental health, and mental health is a clinical thing. So I would say yes, but it depends on really what you're doing. If you're just triaging calls and not really talking to anybody, then probably not. But if you're really talking to them, you have your criteria and you know where to transfer them if you need to, or give them the resources they need to. I think that's pretty clinical. But again, like all of these are my opinion, and from what I've seen working with different admissions committees, not every admissions committee is the same, and so this should not be taken as a blanket statement. Kind of use your own judgment as well. Okay. Do you fill out the form again if you already have? So if you've done, if you filled out the waitlist form already and your name is already there, you don't have to do it again. If you're unsure though, feel free to fill it out again. You guys are awesome. Thanks for offering to help. COVID cases in California are really bad. hospitals are filling up, and it's getting. From my experience, it's getting worse. But hopefully with some of the more restrictions that were placed, hopefully it'll be better. Yeah, it's kind of bad everywhere. So, all right, guys, if there's no more questions, I will let you guys go. Stay safe. Be safe. Talk to your family. Talk to people that you haven't been in contact with. I think I'm seeing a lot of depression and anxiety because of the isolation. So take care of everybody around you. All right. Have a good day.